let's finish up with chapter 5 material right here. We talked about the epidermis, and remember, anything that's highlighted is going to be something that's going to be very important on the test. So if you see an actual slide that has many highlights, well, that's going to be a pretty high yield, very important slide to really get to memorize. So we talk about the epidermal strata. The epidermal strata is the layering effect of what we see of the skin. So when we see the epidermal strata, that is how the skin itself is layered. And there's basically 5 main layers on all of these in our skin. Now, depending on where we're going to see the epidermis, you might have a 5th layer. In other areas, there's only 4 layers. The biggest difference between them is this area that's about 1 layer down from the very most superficial layer, and that's a stratum lucidum layer. Now, in thick skin, which we'll talk about, in which we have talked about previously, the thick skin itself has has an extra layer of strata that is not found in thin skin. Now that's different than what we're going to see when we have a callus. So thick skin is, let's say, the palm of your hands, the soles of your feet, areas of our body that we are intentionally using to manipulate the environment, whether it's grasping something with our fingers and our hands, using our toes to touch and feel the surface of the flooring and the carpeting. These are all just kind of sensations that we have, and with those regions of the skin, we're going to have increased levels of sensitivity in those regions. And even though it doesn't kind of seem to make sense, even though we have 1 extra layer in thick skin, the crazy thing is that 1 extra layer that we see in thick skin really doesn't affect the sensitivity of the skin itself. So in areas where we do have thick skin, where we have that extra layer, we actually in fact have increased sensitivity. So increased pain perception, increased light touch perception, increased perception to texture, all felt more likely on our fingertips, on the soles of our feet, on the palms of our hand. All right, and that region is considered thick skin region, and it has this area that we call the stratum lucidum layer. Now, when we continue forward right here, we talked, I think at the end, we talked about and I will go over just a little bit more detail, the physiology, and then talk a little bit about burns, talk a little bit about cancers as well. So again, none of the pictures will be on the exam, but I will ask questions specifically and in pretty good detail about some of the functions of the integumentary system. Some of them is very simple, but in order to answer these questions online for your first lecture exam, you will need to know it in pretty good detail. In other words, right, if I ask what are the functions of the integumentary system, you can't just say protection, you can't just say sensation or temperature regulation. You will need to know the details. How does it go about with protection? How does the skin affect our temperature regulation, which is a huge function of the skin? So when we talk about protection, the multiple layers of cells, including even the keratin above it, is going to be used as protective against abrasion, rough forces that can kind of shear the actual cells away from the lower regions. Now, the sloughing off, this protection against abrasion, is really protective as well against bacterial overpopulation. So what happens is we'll always have bacterium on the surface of our epidermis, but due to the fact that we have the cells from the very bottom being pushed from newer cells, then those cells, after a couple days, gets pushed up further with even newer cells. So each new cell pushes the older cells closer to the surface. Eventually, the cells closest to the surface will exfoliate out, and by sloughing off those cells, bacterium as well goes with it. So it helps protect, so then we have a nice population density of bacterium, not too high, but we also need to have a good amount of healthy bacterium, so then the bad bacterium doesn't overtake the entirety of our integumentary system. Melanin helps protect against the ultraviolet radiation. Remember, with melanin, you have those melanocytes release the melanin in contact with ultraviolet radiation. So the more ultraviolet radiation, the more melanin gets released. The more melanin that gets released, the more of those cells, those keratinocytes that make up the stratified squamous cells, those keratinocytes pick up the melanin and it darkens those cells. As those cells darken, it is protective against that ultraviolet radiation. It's a reason why we tan in the presence of sunlight. At the same time, if you're wearing a shirt, if you're wearing an Apple Watch, what happens is those areas, if you're outside for a long period of time and you have a t-shirt on, you have your watch on, well, those areas gets blocked from the ultraviolet radiation of the sun. So the sun doesn't hit those areas. And in those areas, you don't have melanin production. So those areas don't darken. That's why you see a farmer's tan on people who've been out at work and they're wearing kind of a t-shirt throughout that whole time. Now, when we look at ultraviolet radiation and melanin, it's very protective, and we will see that even though it's protective, it can give you a false sense of security. And we'll talk about why in a second. The last thing in terms of protection, acts as a waterproof sealant. There's a reason why when you could be at Wisconsin Dells and be out in the swimming pool for hours and hours at a time. At the same time, water doesn't flow into our cells and cause our cells to swell. Actually, the opposite occurs, right? If you're swimming for a long period of time, or if you're in a bathtub for a long period of time, after you get out, your skin kind of looks wrinkled. And it's wrinkled because there's a little bit of water loss. Now, the reason why we don't have a lot of water movement, even though we might be in the pool for a long period of time, is because we have the epidermal cells. As they start to migrate upwards, they start to release more and more fats, lipids. The fats are very, very, very hydrophobic, meaning the hydrophobic nature of that fat stops water from penetrating through our skin, as it prevents that water entrance or water loss. What happens then is that now you have a waterproof seal that is seen just due to the fact of a little bit of lipids being released from those keratinocytes as they migrate upwards. Sensation, and we'll talk more about this in chapter 13 and 14. Pressure, temperature, pain, tickle, itch, heat, cold, those are all sensations that are going to be monitored by the integumentary system. And we'll talk about each one separately in the coming chapters. Temperature regulation. This is a big one. If you understand this one, you're in pretty good shape. In terms of temperature regulation, it allows us to sweat and radiate heat away from our body when it's hot outside. And when it's cold, it allows us to close everything down and retain body heat so that we can keep the core of our body nice and warm. Now, there is a drawback to that though, and we'll talk about it in a second. So let's break this up into two separate conditions. One, when it's hot, and one when it's cold. Now, when it's hot, what happens? Now, depending on if it is very dry heat versus wet or humid heat, we have some kind of situations that we tolerate better than others. Now, most of us would rather, we always say we like dry heat more than that humid, wet heat. And there's a reason for that, right? So what happens when it's really dry and hot? What occurs is this. Your body produces this watery sweat. And because it's about 90% water, that sweat goes right onto the surface of your skin. And since it's dry heat, that sweat evaporates immediately, cooling the skin. What happens then? Blood vessels in your dermal papilla, close to the epidermis, those blood vessels vasodilate. As they dilate, now you bring more blood through that very superficial capillary beds. And now you have the coolness of the skin because you have radiated that, because you have that, the sweat that evaporated. Now you have that cool skin and warm blood right underneath it. That warm blood now can transfer its heat outwards to the cool skin, allowing you to radiate that excess heat away. Now, what happens when it's humid? When it's humid, what happens is this. You still sweat. You still produce this watery, wet kind of sweat. But because there's so much water in the environment, when you sweat, it does not evaporate. Because it doesn't evaporate, it doesn't cool your skin at all. Instead, now you have a layer of water on your skin that actually causes your skin to actually feel a little bit warm to the touch, right? And what happens? Well, because there's no evaporation, you don't have a temperature difference between your skin and the blood vessels underneath it. And because of that, you can't radiate as much heat away because in this kind of dry heat, you can have that cool temperature occurring. Well, when it's wet heat, there's no coolness in the skin. So you can't radiate that heat from your dermal papillary blood vessels. When that happens, you can't radiate out excess heat and you will retain that heat. Your body temperature will then, even though we try to cool it, it can't cool. Now, on the other hand, what happens when it's cold out? When it's cold out, let's go over here, right? When it's cold out, the last thing we want to do is vasodilate and sweat, right? When it's cold out, we don't want blood going to those dermal papillary capillaries. If it does, we lose too much excess heat. And even though we're already cold, we would even lose more body heat, which is not a good condition. That's hypothermia. So what the body does instead is it vasoconstricts the blood vessels that are leading to the dermal papilla. Because those blood vessels are now vasoconstricted, you're not going to lose as much heat outwards by way of the skin. Instead, the blood then gets detoured to the deeper blood vessels, bypassing the superficial blood vessels closer to the skin. That happens, but there's a cost, right? The cost is this. If I maintain this vasoconstriction for a long period of time, let's say my face, my nose is now exposed to the elements and it's been 0 degrees for the last few hours that I've been outside. Well, what the body does is it's going to vasoconstrict the blood vessels near the surface of my nose. Very little blood then goes through those blood vessels. So a lot of the cells that relied on that blood is no longer receiving the blood. At that point, those cells will start to die off. As they start to die off, we will now start having a little bit of frostbite seen. And that's usually where we start seeing frostbite, is in the nose, the ears, the tips of your toes, the tips of your fingers. In other words, the distal extremity regions. So those regions have very kind of fine amount of blood flow to start with. And when it gets cold, we vasoconstrict, and those regions get less and less blood flow going through those regions. Such small amounts that eventually it's not enough to maintain the life of those cells that really required the blood flow. As those cells start to die, we start having frostbite, we start having gangrene as more and more cells die, and now we're going to have the necrosis, and usually the nose might fall off, distal regions of the fingers might die off as well. The last, well, there are a couple more, but the last one I want you to know in a little bit more detail is vitamin D production. Vitamin D actually our body produces an inactive form of vitamin D. This inactive form is called 7-dehydrocholesterol. Again, there's cholesterol again, right? We need a cholesterol to produce testosterone. We need a cholesterol to produce estrogens and to produce bile salts, right? We also know cholesterol is very important for the integrity of our plasma membrane. So cholesterol is very important. Cholesterol is also the basis of vitamin D production. So we have this 7-dehydrocholesterol. What we need to do to turn it into vitamin D is have to have multiple rounds of co-activation, right? So you have an inactive starting material here, and the very first step requires this 7-dehydrocholesterol to be exposed to ultraviolet radiation to form a secondary material called cholecalciferol. Now, this isn't the final product though, right? So it starts the process, but it is not the final product. This cholecalciferol goes into the liver and then into the kidneys, where you have further modification to form calcitriol, the active vitamin D. Again, without that ultraviolet radiation though, you do not start the process. So this vitamin D that we inherently make in our body is made a little bit prematurely, right? You need several more steps to activate it. So one of the steps, and the very first important step, is ultraviolet radiation. Now, once you have that ultraviolet radiation, then it goes into the kidneys, it goes into the liver, where you'll finish off the production of this calcitriol. Now, obviously in Wisconsin, during the winter, we're not going to be exposing our skin into a lot of sunlight. So the one thing we can do then is to actually take vitamin D as a supplement. This vitamin D supplement then, right, will be then going to replace our native endogenous vitamin D. And it's very important because vitamin D promotes calcium phosphate, right? And it promotes the ingestion, the storing of vitamin phosphate. Now, the bad thing is if you take vitamin D and don't take enough calcium, that's actually something that is not great for our body. So whenever you take vitamin D, you need to either eat enough cheese, drink enough milk, or you need to take a mineral, the calcium mineral, along with the vitamin. You need both. If you only give yourself vitamin D, all right, vitamin D is, and we'll talk more about it in the next chapter when we talk about bones. All right, vitamin D is worried about your blood calcium level. That's why I highlight it right here. It's worried about your blood calcium level. If your blood calcium levels goes down and you are only taking vitamin D and taking no calcium, well, what vitamin D does is that it will accelerate the breakdown of your bone material, so then you can release calcium into the bloodstream from your bones, which is where you stored it. So in other words, we know vitamin D is good for us, but only if we're taking calcium with it. And we're taking vitamin D and calcium, right? The vitamin D promotes the calcium that you just ingested, promotes it to be absorbed and be placed into the bone. If you take vitamin D by itself, and don't take any extra calcium, it might actually cause more bone destruction. Because again, vitamin D is only worried about your blood calcium levels, not the amount of calcium in your bones. Your bones are only there to store calcium. If your blood calcium levels are low, guess what? You're going to destroy more bones, release that calcium from the bones, and introduce it into the bloodstream. So it's best to take that vitamin D and calcium at the same time. Now, take a look at all the functions of calcium. Bone growth, bone formation, bone repair is going to be very important, incredibly important for blood clotting. It's going to be very important for all of our nerves to fire and form action potentials. It's going to be very important for your skeletal muscles, all right, as they start to contract. So a lot of different functions besides just what we see in the bone. Remember, bone is just a way of just storing it for the future, as well as allowing you to have any kind of repair after we hit puberty or we have damage. Excretion, removal of waste. Sweat contains a little bit of water, salt, urea, ammonia, and uric acid. Compared to the kidneys, the sweat is going to release very few amounts, very little of each of these. We say it's pretty insignificant. Now, effects of aging on the integumentary system: skin becomes more easily damaged because the epidermis thins and amount of collagen decreases. So what happens is cuts that you don't even feel, or you might even not get a paper cut, because you're young and your collagen is nice, thick, and strong. Your epidermis is thick. Well, in us, we might even, if we get even a paper cut, is very minor. In people who are elderly, they might actually get really hard to stop cuts, all right, bleeds, just from a paper cut. Now, I remember a few years ago, I had my mother-in-law, believe my grandmother-in-law, right, had a cut in her finger, and the normal cut in a finger in us would have just caused it to bleed. For her, she needed to go to the ER. She had to get stitches, and it basically looked like it was about to be completely amputated, right? And it was just a small little cut that for us would not have gone as deep. And because she was older, because of the associated effects on the collagen and the thinness of the skin, it cut much deeper and caused a lot of other issues. Now, what else happens, right? Usually we see that when it's cold or when it's hot, the people that are most severely affected, maybe even cause them to die, are usually the elderly. One of the main reasons is this, right? Decrease in blood supply as we get older causes the poor ability to regulate body temperature. So when it's warm out, they have a harder time thermoregulating and cooling themselves, right? When it's cold out, they also have a hard time warming themselves. So you have all this, and it's all very detrimental, and it can cause some really bad effects. Now let's talk about cancers and burns. Now we look at burns right here. There's 3, and usually we see that sometimes there's a 4th, right? A 4th degree burn. And the 4th degree burn, you burn all the way through the bone. And that's pretty bad burns, obviously. The 1st degree burn goes through into the stratum basale. 2nd degree goes into the dermis, but it stops before you hit the subcutaneous tissue. The 3rd degree burn is full thickness burns. These are the worst. The problem with 3rd degree burns, and usually sometimes it's actually a godsend, is that usually with full thickness burns, you usually burn out the actual nerves. So you're not going to have the same sensation of pain as you might have with 2nd degree burns. So 1st degree burns, we're talking usually about the epidermis being affected. You will have, at that point then, right, some kind of pain, but the pain is not going to be overwhelming. Its best example of this is a sunburn, right? Now, 2nd degree burns, all right, destroys the epidermis and enters part of the dermis. Again, it can go into the dermis as long as it doesn't spread into the subcutaneous tissue. Now, the big telltale part of a 2nd degree burn, right? The sign that we see is that 2nd degree burns usually becomes blistered, right? So you have fluid-filled blisters that start to develop when we see a 2nd degree burn. That fluid-filled blister then separates your epidermis from your dermis. And that's one of the reasons why they always tell you to not kind of pop your blister with a needle or anything, because you are, in fact, once you have a blister forming, you're having that fluid separate the dermis, where you see your blood vessels, from the epidermis, where it's avascular. So if you would pop the blister with a needle, right, just the presence of the needle going through the epidermis pushes a little bit of the epidermis into the area of the blister. Since you have bacterium lying on the epidermis, pushing that internally can seed that region with bacterium, and now you're more likely to get an infection because there are blood vessels in that area now. Again, when you have bacterium on the surface of your skin, in your epidermis layers, well, it can't penetrate through, and it can't go into the bloodstream because your epidermis is avascular. But once we introduce it into the dermis, once we introduce the bacterium into the subcutaneous tissue, that bacterium can spread anywhere at that point. It's going to become real focally infected, but there's such big blood vessels there that it might start to become septic. Now, usually with 1st and 2nd degree burns, they're very, there's healing, usually without having to do a skin graft, right? In terms of 2nd degree burns, the stratum basale cells are not destroyed, And because they're not destroyed, you can heal without a skin graft, even though some scarring may occur. Now, in third or full thickness burns, you will have burning all the way through the dermis, all the way into the subcutaneous tissue. What we will normally see, like what we mentioned, blistering is indicative of second-degree burn. Well, charring is pathognomonic, meaning indicative, really strong indication of a third degree or full thickness burn. So we see charring, right? When we see charring, the epidermis, dermis, and anything lower than that will get destroyed. Now, like I mentioned, right? With this, since it's full thickness, the stratum basale cells are completely destroyed. So there's no way you'll have proper healing unless we have some kind of skin graft. Usually, at that point, even the fatty tissue underneath will be destroyed. That's where we see that charring effect. And in severe circumstances, bone, muscle, all right, especially muscle, might also be burned away. Now, in that process, it's very painful, but after a while, though, you will start having loss of sensory neurons. Because of that, you no longer feel the pain, and that area that's damaged is usually numb from that point on. So here's some examples of the, all right, first degree, second degree with the blistering, and then third degree. Again, there are fourth degree burns, but with fourth degree burns, we're talking about somebody that's stuck in a home, can't get out, and now they're completely burnt away. All right, at that time, right, not only will we see the charring and a fourth degree burn, but you'll see bone sticking out and actually bone tissue that will be burnt as well. Here are more examples of second degree. Here's a combination of second and third degree burning. If you take a look right here, notice that the little boy right here, right, has a little bit of his chin also have components of second and third degree burns. This would be incredibly painful. And usually this happens when a child is reaching for something on the stove and it's either hot water that's boiling or, God forbid, hot oil, right? And that oil starts to kind of fall down from the pot. That water that's super hot starts to fall down. They're able to turn their face away, so only one side's affected, but they have a hard time turning the torso away. And now the torso here is completely affected. This would be incredibly painful. So this poor kid is probably going to have to go through many rounds of skin grafts to fix this up. Right, now we do something called the rule of nines. Right, the rule of nines means that, right, depending on where we are, the head region, if it gets completely burned, that's 9% of the body. If your arm, either arm, right, is burnt completely, that's another 9%. If your anterior torso, right, is burnt, that's another 9%. If your trunk posteriorly is burnt, that's another 9%, right? Eventually we get to the 100. Normally, what we normally see is when people have greater than 65% of their body that contains third degree burns, there's usually very little chance of long-term survival, right? The reason is with third degree burns over a large portion of the body, there's no way to retain, all right, your body's water content. So without the skin intact, right, since it's all third degree burns, it's no longer intact in those regions. What happens is you will lose fluid as soon as I pump it into your IV. And at that point, all right, we can keep pumping it, you keep losing it. Eventually, you go into hypovolemic shock, right? And after like 75% third degree burns throughout your body, very, very, very few people survive past the 24-hour mark. Right, skin cancers. There's 3 basic forms. Now, there are some other kind of stray forms, but these are the 3 most common forms: basal cell carcinoma, squamous cell carcinoma, and malignant melanomas. Know the differences, know which ones are most dangerous, which ones are least dangerous, which ones come from moles, which one comes from, right, certain type of cells, like the cells of the stratum basale. So hopefully the name of the cancer helps us discuss what type of cell there are, what kind of cells are initially affected. So let's take a look at squamous cell carcinoma. Now, squamous cell carcinoma has intermediate lethality. They can move to other regions of your body. In other words, they can metastasize, but they more often don't. So compared to the basal cell carcinoma, where they rarely metastasize, well, squamous cell is a little bit more risky than basal cell, but not as dangerous as malignant melanomas, which are the most dangerous ones. Now, as cancer, right, as long as it stays in place, stays in situ, any cancer is not as dangerous if it stays in situ, even if it's very big, right? Now, the one place where it does matter, where size matters, is if you have any kind of brain cancer. But besides brain cancer, all right, if you have a 10-pound mass on your leg, that's less dangerous than having a small cancer that have now moved everywhere else, right? We call the movement metastasis. Once a cancer is metastasized, the mortality rate goes up exponentially. So let's talk about this squamous cell cancer that sometimes metastasizes. So it can metastasize and cause an increase in the death rate, mortality rate. These are cancers of our squamous cells, which are our keratinocytes. So if you look at squamous cell carcinomas, they look like little cankers or sores that's occurring on the skin. Now, if we see them grow big on that one area of the skin, it's actually a good sign that it hasn't metastasized. The worst conditions we see are ones that are very, very small, but have migrated and metastasized to distant regions of our body. So this is what squamous cell carcinomas look like. They look like little pressure sores, little ulcers in our skin. They rarely, they may metastasize, not as common though, as when we consider the malignant melanomas. Right? Now, all of these cancers, all of them, have greater indication in areas where you have ultraviolet radiation, right? So the more sunlight you have, right, in that region, the more likely you're going to have any of these skin cancers. Skin color becomes very important as well. The lighter skin you are, the more likely you are to have all three types of cancers. The bad thing is this: even though people who are darker skinned have lesser prevalence of skin cancers, the mortality rate, though, in people with darker skin that get skin cancers like malignant melanoma, well, the worst thing is that the darker the skin, the worse the indication. Meaning that, right, the darker the skin you have, if you somehow get malignant melanomas, right, usually you find that and you get diagnosed at a much, right, kind of a much further down the disease progression. So it might have already metastasized. So the mortality rate is actually higher, right? So we have to be very careful. Basal cell carcinoma, they rarely metastasize. These come from cancers from the stratum basale cells. Because they rarely metastasize, these are the least dangerous. So you take a look at these. These look like little, real big abrasions right here. Now, obviously, for this person, it has taken a long time for that, right, basal cell carcinoma to get to this stage. Hopefully, we get it before the hand, right? But with them, we're going to have to do a complete removal of the nasal bone, complete removal of the skin and subcutaneous, and maybe even a little bit of the septum, right, the septal cartilage here, right? And you will need total reconstruction of the nose after it. But the good news is usually not a life-threatening condition because there's an attack on the epidermal cells, the stratum basale cells, in that region, and it occurs usually in situ, at that site only. Does not metastasize. Now, the most dangerous one is malignant melanoma. With malignant melanoma right here, they metastasize rapidly and they can be life-threatening almost immediately. Now, even though we don't mention it here, there's actually two main forms of malignant melanomas. There is the ones that kind of stay in sight and they spread around the actual epidermal region. So they spread more laterally than internally, right? The actual ones that kind of spread laterally in that area, it's usually a little bit less dangerous. Remember, it is the metastasis that then becomes life-threatening. Now, the ones that spread radially, right, that spreads deep and starts penetrating into the blood vessels, those are the ones that become more likely to metastasize quickly, and that immediately becomes life-threatening. With malignant melanomas, they always arise from collection of melanocytes. Now, you guys have heard of moles before. Moles are going to be melanocytes that have congregated in one region of the epidermis. As they congregate all together, it starts to build on top of each other, and then you have the melanocytes start rising and tenting upwards above the epidermis. But usually the mole should be darker, right? It should be full of melanin because those are a collection of melanocytes. Now, freckles are basically very similar to moles. The difference between a freckle and a mole is that freckles are a collection of melanocytes, but as they collect in that area, it stays flat. It doesn't tent up and start to rise above the epidermis. So you can get malignant melanomas, right, arising from freckles that have started to mutate. So all malignant melanomas comes from these cells, those melanocytes that have started to change, started to mutate, and now starts to grow unfeathered. Now, we do have the ABCDs of malignant melanomas. The ABCDs include, right, A for asymmetry or symmetry, B for border, C for color, and right, and size, right? Now, D for diameter, which is going to be the size. So diameter is a D. Now, right, again, A, symmetry or asymmetry, B, border irregularity, C, color change, and D, diameter, which tells us the size. So let's take a look at this right here, and we'll see, right? Take a look at this malignant melanoma. A mole should be nice and circular, right? The borders should be nice and clean. So if you look at it, it should be nice and straight coming down. If you take a look at it, this is very jagged. You have cells coming out here, right? Now, what else do we see? That you see some growth of those malignant cells right here as well, and over here. And worse, you see a change in color right here as well. So now we don't have any symmetry. A symmetry is like if I cut it in half, the left and right side looks the same. Right here, if I cut it right here, the left and right side looks completely different, right? So we don't have symmetry, so we have asymmetry. Then we have a change in size, right? Then we have a change in color. And then we have a change in the border. Should be nice and circular. But now, because the cells have become cancerous, they start growing everywhere. And there's no order to the growth. When that happens, it can happen anywhere. And now you start having this weird looking shape to the mole. Right? Now, again, right, you can start seeing it over here, just the change in color. You can see the change in the border irregularity. It's nice. It's no longer nice and round. There's no longer symmetry either. So once you start seeing any of those, especially a change in color, you have to get it seen by your doctor immediately. We do not want it to happen what happens to this guy right here. All right. Now, the weird thing is this usually start as a freckle inside his mouth. The growth has occurred really quickly, and you can imagine that how do you even eat at this point, right? Well, this person, he can't. And if you would look at the whole picture of him, he's very malnourished. Now, the question is, why did he wait this long? Same thing with this guy, right? Don't know, right? But the only good thing I can tell you is, even though it looks terrible at that point, right? Usually when any kind of cancers start to grow, if it grows larger in that site, right, in that area, that means there's lesser chance of it metastasizing. So after we give them radiation therapy, after we give this person radiation and chemotherapy, then we can hopefully do surgery to remove it, right? And usually that should be good enough and almost curative, because if it's growing this large in that area, usually is a sign that it hasn't metastasized, right? So I will stop right here.